Welcome to today's presentation on joints. You'll be learning more about joint structures in Lab 5, and this is Blosson Chapter 9. In today's presentation, we'll be taking a look at 9.1 through 9.6. Do not go on to 9.7, and I also have a few additional slides that I'll share with you. Those additional slides are posted in the Exam 2 folder underneath this presentation. So as we begin this conversation, we're going to see that a joint is basically where two bones come together, where an articulation occurs between two bones. There is typically cartilage in between the bones. That is most oftentimes hyaline cartilage, but we'll see a couple of examples where there's fibrocartilage. And the type of connection between the bones will allow for little movement, a little bit of movement, or a lot of movement. So we'll be describing joints in a couple of different ways, both functionally and structurally. So let's take a look at this. Read through this introduction, gives you a good sense of what joints are. Again, simply the articulation surfaces of bones that allow little to no movement or significantly more movement. So let's start by taking a look at structural classifications of joints. There are three structural classes of joints. There are fibrous joints. This is where bones come together. They are held together by a fibrous connective tissue, and we'll be taking an entire look at fibrous joints in 9.2. Then there are cartilaginous joints. This is where bones are connected not by a little bit, but by a big chunk of hyaline cartilage or fibrocartilage. And we'll have an entire short section on cartilaginous joints in 9.3. And then finally, there are synovial joints. These are the most common type of joint found in the body. These are joints that have synovial fluid around them. They are freely moving joints. That synovial fluid acts as a lubricant, and we'll study these the most. And synovial joints are described more completely in section 9.4. So we'll get there in a few minutes. The other way, however, to describe joints, and these go hand in hand, are functional classifications. And this is going to be basically a name to describe the amount of movement that can occur, what functional movement the joint is able to allow the body. So we're going to see a couple of different terms. Synarthrosis. A synarthrosis is an immovable joint. I'll describe those in a moment. Synarthroses, or a synarthrosis joint, are typically your fibrous joints. Then there are amphiarthrotic joints. They are slightly movable, and the amphiarthrosis type joints are oftentimes your cartilaginous joints. And then finally, there are diarthrotic joints or diarthroses, and these are freely moving joints, and your synovial joints are described as being diarthrotic. So we'll see that these terms typically, these three functional classifications are parallel for the most part with the three structural classifications of joints. So let's get started with synarthrosis. Again, a synarthrosis is an immovable or nearly immovable joint. Make sure you're watching these videos. And a good example of synarthrotic joints are sutures. You have learned in lab 4 different sutures, 3 of which are labeled here in this skull. There's the coronal suture. You know that this is where the frontal bone comes to meet with the parietal bone. There's the squamous suture, which is between the temporal bone and the parietal bone. There's the lambdoid suture between the occipital bone and the parietal bone. And you know that across the top of the skull there is a suture which connects the two parietal bones to each other. So your sutures, touch your skull, are not moving. So these are immovable joints, okay? And so the sutures are a great example of synarthrosis. Another good example of a synarthrosis is the joint between the manubrium and the sternum, right? The manubriosternal joint, the connection between the manubrium. You've learned that the sternum has three parts. The most superior part is the manubrium, the body is the majority, and the xiphoid process is the pointed, more inferior portion. So where the manubrium and the sternum the body come together, man, that's a great example of a immovable joint as well. Then we have amphiarthrosis. Again, these are joints with limited movement. Limited movement. You can watch the video here. And a good example of a amphiarthrosis are the cartilaginous joints that unite the bodies of the vertebra. So you know that the bodies of the vertebra are separated by an intervertebral disc. That disc is largely composed of fibrocartilage, a very weight-bearing, tough, fibrous type of cartilage. And every day as you walk, this intervertebral discs, or all of these intervertebral discs, actually get a little bit squished. So that's why at the end of the day, you're a little bit shorter. And then when you rest at night, those discs are able to re-expand, and you're a little bit taller in the morning as a result. Now, these joints, there's just a little bit of movement between your vertebrae, right? Just a little bit of movement. So that's a good example of a amphiarthrosis. Another good example is the pubic symphysis. Remember the word physis. The term physis means growth. Sym means to come together, right? So you go to the symphony, right, to hear the phonies come together, the symphony, the sounds come together in the orchestra. And symphysis is basically a term that means where things grow together. The pubic symphysis is where the two pubis bones grow together in the front of the pelvis. There is a big chunk of cartilage here, and that cartilage makes this a cartilaginous joint, but also has a little bit of movement, and that movement is especially evident during childbirth, where the pelvis expands for childbirth, and so this is an amphiarthrotic joint. Then we get to diarthroses. Diarthroses are freely movable joints. Freely movable joints. And your synovial joints are all classified also as diarthrotic joints. Okay, they are the most common. They provide most of the body movements that we all know and experience every day. And we'll divide these movements up into 6 different movements in section 9.5. These diarthroses can be classified as uniaxial, meaning they move in just one plane. Think the knee or the elbow. There are biaxial movements where things move in 2 planes. And then there are multiaxial joints where bones are able to move in multiple planes. So again, the elbow and the knee are good examples of uniaxial joints, freely moving. Biaxial joints, we'll see a couple of examples of these in the hand. For example, your knuckle joint, which could be described as the metacarpophalangeal joint. Break that down. It's between the metacarpals, right, the long bones of your hand, and the phalanges. Look down at your hand, right? Think about where your metacarpals are and where your phalanges are, and where those come together. You agree, make a fist. That's where your knuckles are. So those are biaxial joints because not only can you bend your fingers at the knuckles, but you can also spread your fingers apart at the knuckles. And then finally there are multi-axial joints, The two that I will be referring to most that are multi-axial will be your shoulder joint and your hip joints. And we know that those are very movable joints. So we'll continue to look at this in multiple ways. Whenever I come across any bony image today, I am going to stop and point out bone markings. You're busy learning your bone markings, and I want to reinforce that. So let's take a look. Here we see the femur. Here's the head of the femur. Here's the neck of the femur. This big bump is the greater trochanter of the femur. The head of the femur is articulating in this cavity. This is the acetabulum. The acetabulum, and this is the articulation right between the femur and the hip. We also see here this large opening. This is the, do you remember the name of this foramen? That is the obturator foramen. And again, the hip joint, better known as the coxal joint, that's the anatomical name for this joint. This is a multi-axial joint. So that's a quick review of the ways in which joints are classified. Don't forget to look at the questions and the vocabulary checkup at the end. Let's take a look at the fibrous joints. Okay, fibrous joints. Now, fibrous joints are joints that have very little movement. So these fibrous joints are also considered the synarthrosis. There are three key examples. One I've already described to you, and that is the sutures. Right? There is a dense fibrous connective tissue that connects the skull bones together, the cranial bones together to form the sutures. Two other examples. One, and you may never have thought about this before, but because when we look at our skeleton, we see that the ulna and the radius are two bones. They're parallel to each other most of the time, but they're just two bones hanging out next to each other. What you don't appreciate from looking at pictures of skeletons is that there is a connective tissue, a ligamental structure that connects these bones. They are not separated with space. I mean, well, take that back. There is a membrane in between these bones, and this is meant to be a structural connection, not a moving connection, simply something that holds these two bones together. So that is considered basically a ligament, right? It's an interosseous between the bones. There's a membrane. This membrane is a ligamental-like structure. And then lastly is how your teeth are held into the socket of either your mandible or your maxilla, or your upper or lower jaw. So the tooth fits into a space and is held in place by the periodontal ligament, right? The periodontal ligament, bone-to-bone connector, and this type of connection found where the teeth connect to the bones is called a gomphosis. So a gomphosis, there's a new word. A gomphosis is a particular type of fibrous joint where the tooth is anchored into the jaw. So those are the three examples. A little bit more information here about them. You also have learned in lab about the fontanelles. The fontanelles are the soft spots, if you will, of a newborn. And there's the anterior fontanelle, the posterior fontanelle, the sphenoidal fontanelle over by the sphenoid bone, and the mastoid fontanelle, which you will recognize is close to the mastoid process of the temporal bone. So these are the soft spots of a newborn, and these spaces fill in as the cranium grows after birth. Another example is a syndesmosis. This is basically a connector at the end of the bone. So here we're looking at the tibia and the fibula. We're looking at an ankle area. And the tibia comes down and sits on the talus. On either side of the talus, there are two projections. On the tibia, you have the medial malleolus. On the fibula, you have the lateral malleolus. Okay, again, I'm just pointing out bone markings. These will become more and more familiar to you as we continue. The talus articulates with the calcaneus, that's the largest bone of the tarsal group. And then just in front of the talus is a bone called the navicular. So this bone that I'm pointing to here is the navicular bone. There are then three wedge-shaped cuneiforms, right? Three wedge-shaped cuneiforms. Here is the lateral, the middle, and the medial cuneiform bones. The only bone that I've not been able to show you of the tarsal group is the cuboid bone, which is on the other side here of this navicular. Make sure you are reading through the text. And then here is a video that describes echomphosis, the connection between the ball and the socket of the oral cavity and the tooth. So those are examples of fibrous joints. There aren't that many, as you can see. Little quiz here on this and a vocabulary checkup. Moving on to cartilaginous joints. Again, just a couple of examples here. One of the most famous examples, if you will, is the pubic symphysis. Right? The pubic symphysis is a big chunk of cartilage that is forming and connects the two pubis bones. This is a chunk of fibrocartilage, right? Tough type of cartilage. Then the other example that you've already seen in the bone discussion is the epiphyseal plate. I mean, think about it. It really is the connection between the epiphysis and the diaphysis of the bone, and that cartilaginous connection, you remember, is made of hyaline cartilage. But that's an example of a cartilaginous joint. Now, we know that this cartilaginous joint, over time, when the bone reaches its adult height, that cartilage is no longer. This becomes the epiphyseal line, and the blood vessels are able to penetrate and connect with each other. And so here again is the description of the symphysis, the pubic symphysis. So read through about cartilaginous joints. These are typically amphiarthroses, right? Amphiarthroses. They have a little bit of movement, just a little bit of movement. And then finally we get to synovial joints. Again, these are the most common types. Synovial joints are going to have a synovial membrane around them that provide a fluid-filled sac. That synovial fluid is going to provide lubrication and nutrients to the cartilaginous structures of the joint. So this is a generic synovial joint. This is not any particular joint, but we just see two bones coming together. You do see the hyaline articulating cartilage where the bones would come into near contact. But what's different is that there's this joint space filled with the synovial fluid. That capsule that is around it is going to hold in that fluid. So here we see again the coxal joint, right? This is the hip joint. You can see that the head of the femur is up in the acetabulum of the pelvis. Here's the neck of the femur. Here is the greater trochanter. There is that obturator foramen once again. There are ligaments that are going to hold the bones together. We'll see when we get to specific examples of different joint structures, we'll see the ligamental connectors. The great news about ligaments is, well, first of all, we won't be naming very many of them. You'll see a few specific ligaments in Lab 5 when you're learning a few isolated structures from different joint structures. But you'll see that these ligaments connect bone to bone, right? And they're going to hold and help to hold joints together. Remember also, in addition to different ligamental structures, there's also going to be tendons. Tendons are also made up of dense, regular connective tissue, you know this, that connect muscle to bone. And oftentimes, these tendons are also going to help stabilize joint structures. In some joints, not all, there's an extra chunk of cartilage. This is most famously found in the knee joint, and we'll look at this in detail. But in the knee, there's, in addition to the hyaline, articulating hyaline cartilage, there's also a couple chunks of fibrocartilage. These two pieces of fibrocartilage are called the menisci. Right? Each one's a meniscus. And these are big C-shaped pieces of fibrocartilage that help to stabilize the knee joint. Also, around many, not all, but many joints, there are bursa. Recall from your vocabulary that bursa was strangely defined as a purse, but you can also think of a bursa as a gel pack. And in this picture and in many diagrams, the bursa will be shown as blue. And the bursa are like these gel pack structures. They are going to be found in the joint structures. They're going to help protect the joint from the rubbing of the tendons and of the muscular structures around the joint. The bursa can get infected, in which case a person would have bursitis, right? Bursitis, inflammation of the bursa, which is quite uncomfortable, painful condition. The great news about bursa, like ligaments, is that they name themselves. So you will see that bursa are named for the very place that they're found, and ligaments most oftentimes name themselves for the two bones or the two regions of bones that they connect together. So let's just take a quick look at this image of a knee. We're not going to look at the individual structures yet. We'll do that in a little bit. But in this picture, they've labeled a couple bursa, right? So this is the suprapatellar bursa, right? Supra means above, superior to the patella. So this bursa is above the patella, which is here. And then there's even a bursa that is superficial to the patella, right? That again protects the tendons that are coming down around the front of the knee. And then there's even a infrapatellar bursa. So you see these bursa are wherever bones and tendons and ligaments might be rubbing, and it helps to protect the joint structure. I will point out here a connection from last unit, and that is here is the patella, and you can see that the patella is basically embedded right here in this tendon. So that's, remember, the patella is considered a sesamoid bone. A sesamoid bone is one which is embedded in a tendon, and we can see that tendon for the quadriceps femoris group coming down, and actually the patellar tendon also merges with this, and the patella is embedded within it. So here is a little story about bursitis. I've already introduced that. Go ahead and read about that. And let's take a look at different types of synovial joints. Again, this is the most common type. Most of the joints in your body that you think of are of this type, and all synovial joints, I've already said it, but all synovial joints are diarthrotic in that they are freely moving. Now, of these 6 distinct different types of movement, just like I introduced in the pre-lab video, I believe this is for pre-lab 5, there are only 3 of these that I am going to ask you to know more about. So as we go through this, I want you to be focusing on pivot joint. I want you focusing on ball and socket joint. and I want you focusing on hinge joint. The other three, saddle joint, plane joint, and condyloid joint, yes, they're important. However, they're not as critical, I don't think, to your overall understanding of joint structures, and I will not be asking you for specific examples of these. However, I will say this, condyloid, plane, and saddle joints are all represented in the hand and the wrist. Okay, hand and wrist, also down in the ankle and tarsals. So these are particular types of joints found in the hands and ankles and feet. So let's take a look first of all at a pivot joint. This is definitely one that I want you to know, right? A pivot joint. You can watch this video. The one pivot joint that I want you to specifically know is the atlantoaxial joint. The atlantoaxial joint is the joint found between C1 vertebra, the atlas, and C2 vertebra, the axis. This is the joint around which your head spins when you say no. So right now, just say no, right? Turn your head side to side and recall that your entire head is now spinning on its axis, specifically around the dens of C2. So this peg here in this video, you can think of this as being the dens, that superior projecting process on the C2 vertebra. And so that is the one pivot joint that I want you to know the most about. The atlantoaxial joint is just a fancy word for saying between the atlas and the axis. Hinge joint. There are two hinge joints that I want you to know, and they are the elbow and the knee. Right? So the elbow and the knee. These are the two big hinge joints that I want you to know. And these make sense, right? If you think about just bending your knee or bending your elbow, these are uniaxial joints. They move in one axis, and they are great examples of hinge joints. Again, moving forward, condyloid joints, I put this in blue. I'm not asking you to describe or to know examples of condyloid joints, but I do want you to at least look at the name of this joint. Okay, metacarpophalangeal joint. I'm not asking you to know that this is a condyloid joint, but what I do want you to be able to do is to appreciate what this name is telling you. So what is a metacarpophalangeal joint? Think about it. It's the joint between your metacarpals and your phalanges, right? Metacarpals and your phalanges. So look down at your own hand, right? Think about your metacarpals going through the palm of your hand. Think about the phalanges. Now make a fist where your phalanges and your metacarpals come together. I think you would agree, those are your knuckles. Okay? Now, the condyloid joints, I'll just say, are an example of a biaxial joint. Why? Because you can make a fist, right? And by doing so, you're bending your fingers in one plane, but you can also spread your fingers out, right, like jazz hands, and in doing so, you appreciate that those joints are able to move in two directions, hence their classification as biaxial. Remember, these are also considered diarthrosis. They are freely moving synovial joints. Saddle joints, again, I have in blue. Not asking you to know any specifics or be able to recognize a saddle joint. They also are biaxial joints like the condyloid joints. And planar joints or plane joints or gliding joints, again in blue. Not asking you to know specifically about this. Again, all of these three that I'm having you basically skip over are all found in the ankles or in the carpals or tarsal areas or in the hand. These gliding joints are what are found between the intercarpal joints. Think about that, right? In between, inter means between the carpal bones, and the intertarsal joints between the tarsals of your ankle. The last one, ball and socket, very important. These are the joints with the greatest range of motion. You will recognize these joints as having a ball-like structure that goes into a socket-like structure. The two main examples are the coxal joint and the glenohumeral joint. Okay, they are the two ball and socket joints in your body. Make sure that you're using the anatomical terms here. So the coxal joint is your hip joint. Your glenohumeral joint is your shoulder joint. The glenohumeral joint gets its name because it is the head of the humerus fitting into the glenoid cavity of the scapula. Glenohumeral joint. These are multi-axial joints. They are able to move in all directions. And these are, they have a deep connection, right? So these, like for example, your coxal joint is weight bearing. So there are lots of connections that help to stabilize both your shoulder and your hip joints. Very, very important joints. Again, relatively short sections on this. What can go wrong? Synovial joints can get inflamed. We've all heard of arthritis. Okay, we've all heard of arthritis. Arthritis, and I have a slide on this later on, but arthritis is not a single disease. There are over 100 diseases that are basically a form of arthritis. Arthritis simply means inflammation of a joint. There are hundreds of diseases, over 100 diseases, that have some sort of inflammatory process occurring in joints. Okay, some of these are simply wear and tear, aging of our joints. Some of these are autoimmune diseases. Some of these are caused by infection. Some are genetic and really are unknown. The most common type of arthritis is osteoarthritis. Osteoarthritis is a type of arthritis we can all look forward to getting. This is simply normal wear and tear. And what happens is that the articulating cartilage wears down. Remember, my friends, cartilage is avascular and it does not repair itself. So once cartilage gets damaged, it doesn't have any blood flow. It doesn't have the ability to repair itself. So as this cartilage breaks down, movement becomes very painful as bone grinds against bone. Right? People who have a new knee or a new hip or a new shoulder, it's because they've had arthritic changes and bone is now grinding on bone. And what happens, and what the picture is trying to show you and the video describes, do watch it, is that with that grinding, with that bone on bone changes, the bone becomes ragged and jagged on the edges, and this leads to even more changes. So once that arthritic change occurs, it seems to sort of progress more quickly once it begins. So definitely watch these two quick videos on osteoarthritis of the knee and osteoarthritis of the hip. This little section here just describes, sort of in cartoon form, what a normal knee looks like. The cartilage looks smooth versus the ragged, jagged looking cartilage of osteoarthritis. In this chapter, there are a number of really cool images that describe what orthopedic surgeons do in replacing, for example, a knee. I'm not going to ask you about any of these processes, but you may know someone who has or is considering one of these orthopedic procedures, and this is a great place just to review back to what is involved in this. So shoulders, hips, and knees are the bread and butter of orthopedic surgeons. These processes have become very, very routine. Something that's not mentioned in this chapter is just how routine these have become. For example, I myself got a new hip about 5 months ago. And so basically they cut off the head of my femur. I have it sitting here in a jar in my office. And They have replaced the head that fits up into the acetabulum with a synthetic piece, and a big post goes down into the femur. I was home. I had the procedure done at 9 o'clock in the morning. I was home before noon. So it's an outpatient procedure. I was home and walking upstairs that afternoon. So it's an amazing process, very routine, and a fantastic outcome for me. Another type of arthritis, however, a couple different types. One is rheumatoid arthritis. This is not as common, but this is a autoimmune disease that affects women more than men. And this is a very deforming, painful sort of arthritis where, again, the body's immune system begins to attack the cartilaginous structures of the joint. And then another form of arthritis is gout. Gout is actually a form, it's a dietary imbalance, it's a metabolic imbalance, and this particular form of arthritis affects men more than women. So what I'm trying to point out to you is that there are many different types of arthritis. Some affect men more, some affect women more, some affect both sexes equally. Some forms of arthritis occur as we age, but there are even forms of arthritis that are the result of that occur during childhood. So all sorts of diseases you may have heard of, for example, scleroderma, or you may have heard of lupus, or even fibromyalgia. These are all conditions that, because they include the inflammation of joint structures, are part of that over 100 diseases, which are considered a type of arthritis. Great little videos here about arthritic changes. By watching those, you will better understand synovial joints as well. That brings us to the end of section 9.4. Again, make sure you're addressing these questions and checking out the vocabulary checkup at the end of the section. Let's move on to 9.5, types of body movement. These are all movements that are also described in your pre-lab for lab 5, and the same list of movements are the same ones that I want you to focus on here. Basically, all of these synovial joints in our body are these diarthrotic joints that allow us to freely move, allow our body to move in very predictable ways. And each of these movements has an opposite movement. And what you want to focus on is, what are the opposite movements? So for example, abduction and adduction are opposite movements. Things like flexion and extension are opposite terms. Lateral and medial rotation are opposite terms. So you want to basically think about doing a little dance as you read about these on your own body. Demonstrate what this movement looks like. Also, be sure to watch the videos that are here and think about how you can replicate those movements. There's also dorsiflexion and plantar flexion. Some of these are terms that you've heard of, but maybe aren't really clear on. Some of these may be brand new to you. For example, dorsiflexion and plantar flexion. Interestingly, and what causes confusion here is that they both have the word flexion in them, and that causes confusion. These are two terms that are only referring to movement of the ankle, dorsiflexion and plantar flexion. Another one that causes a little bit of trouble is pronation and supination. Typically, when you are in anatomic position and you have your arms down to your side and your palms are facing forward, your ulna and your radius are parallel. Your ulna and your radius are parallel as you just put your hand down to the side. But in that, we call that supination. But if you now flip your palm to looking backwards, your ulna and your radius actually cross over each other. So when you do that, that's called pronation. So to pronate is having the radius cross over the ulna. When you then flip back and your palm is facing forward, your radius and your ulna are parallel. I remember this easily. in order for me to get my supper, my palm must be supinated, right? So to bring your palm forward, to get food, if you will, is supination. A couple more opposite terms: protraction and retraction. Protraction and retraction. Protraction is any anterior movement. Retraction would be bringing it back. Think of kind of sticking your chin out and then bringing it back. Protraction of the mandible or retraction of the mandible. You could also think about elevation, anything that brings your body upward in a more superior motion, and depression, returning it back to normal or sinking it down. And then finally we have opposition. The opposite of opposition is reposition. Opposition, reposition, opposition, reposition. We are, as humans, we have an opposable thumb. So opposition is simply bringing your thumb and bringing it to your palm, being able to bend your thumb over your palm. That's opposition. And then when you return it back to normal, that is, quote, reposition. So all of these movements have great little videos that help you understand them. Again, I would really just want you to be able to think about what these different movements are, practice them on your own body so that you can just better understand what these motions mean. Abduction and adduction. Again, when we talk about these terms, you always want to have your starting position in anatomic position, right? So in anatomic position, you know what that looks like. Abduction, right? AB means away. Duct means to draw. So abduction is to draw away from the middle, away from anatomic position. Adduction, AD means toward, and that is bringing it back toward the center of the body, back to anatomic position. Circumduction is any sort of circular movement. The best way to describe this, well, here in the video, you're looking at the shoulder, the glenohumeral joint, and you recognize that you can rotate and do a big circular motion with your arm at the shoulder. That's an example of circumduction. You can also just take your pointer finger and you can make a circular motion clockwise or counterclockwise. That's another example of circumduction. So we can do circumduction at any of the biaxial or multi-axial joints. Rotation, again, back to the idea of the pivot joint, our atlantoaxial joint, where we can pivot or rotate. Same thing, pivot or rotate. It's also possible to do rotation. Think about your leg, your lower limb, and you are able to rotate inwardly, right, medially, and you can also rotate outwardly your entire leg. That's at that multi-axial coxal joint. So lateral or external rotation versus medial or internal rotation. Supination and pronation, I already mentioned those. This video will help clarify that for you. Again, the supinated position is bringing the forearm back to anatomic position. Let me get my supper. Whereas when you base your palm backwards, that is pronation. Dorsiflexion and plantar flexion are movements of the ankle joint. Remember, the ankle is a hinge joint. If you have heard of a plantar wart is one on the bottom of the foot. Plantar flexion is sort of like doing toe point. It is moving the ankle away, making sort of your foot as flat as possible, whereas dorsiflexion is bringing your toes up toward your knee, trying to bring that upward. Inversion and eversion. Also, think about your ankle, your tarsal bones, and if you just simply rotate but turn your foot inward or turn your foot outward. So inversion, turning the bottom of the foot inward. Eversion, putting the bottom of the foot away from the midline. Protraction and retraction, again, movements of the scapula or the mandible. Protraction is simply pushing things out, and retraction is bringing it back. Depression, elevation. Depression is bringing it down. Elevation is bringing it upward. Again, good examples on the scapula and the mandible. So take a look at those. And then we also have excursion. Excursion is lateral and medial excursion. Take your lower jaw right now, and your lower jaw, not only can your lower jaw go up and down, right? Your mandible goes up and down to chew. It can also sort of do a rotating movement. I'm kind of doing it now, right? Your lower jaw can move in a circular motion somewhat, but also your lower jaw can move to the left and the right. All right, your lower jaw can do excursion, which is one side of the midline toward the other side. So take a look at these, read through these, watch the videos, and then here is a table that will help you understand what each and every one of these different types of joints, what they can do, and the primo example. Again, you want to know pivot, you want to know hinge, and you want to know ball and socket. Those are the three that you want to know the most about. That brings us to the end of 9.5. Again, review the questions and the vocabulary checkup. Lastly, we're going to look at a number of specific synovial joints. These are all things you've heard of. In lab, you're going to be looking more specifically at the shoulder, elbow, hip, and knee joints, right? Again, shoulder, the glenohumeral joint, the hip joint being the coxal joint. And you're going to be asked to specifically know the bones, the ligaments, the tendons, and the muscles that are involved in those particular joint spaces. I'm going to present a few extra joints to you here beyond just those 4 from lab. What is most important for you as we take a look at these specific joints? I want you to know the bones that are articulating in these joints. I want you to know the movements that are being allowed by these joints. Is it a multiaxial or a uniaxial joint? And I want you to know the structures that are helping to provide protection to that joint. And those are the things that I'll be pointing out as we go through this. So let's take a look at a number of these joints, okay? So number 1, I'm skipping over this first one. So I'm going to put a big old blue section through this. Okay. So I'm not asking you to read through any of that. Oh, I forget you have to do one paragraph at a time on the highlighting. So I'm not asking you to know about the facet joint, so let's not worry about these. But I do want you to know about the atlanto-occipital joint, okay, and the atlantoaxial joint. This is what's going on in your neck. This is what allows you to turn your head. And just watch what I'm saying here. We're looking for the first time at a superior view of the atlas. Okay, remember the atlas is C1 vertebra, and C1 sits on top of C2, the axis. This projection right here is the dens. This is that tooth-like projection from C2. What we don't see, though, in our skeletons is that there is a ligament here. Okay, just a ligament that helps to straddle on either side or around the dens. So now we begin to see that as your head pivots, it's pivoting around this dens. That's why C2 is called the axis, because the head rotates on its axis around this dens. You also see 2, I'm just going to call them landing pads, but these are the superior articulating facets of C1. And you should now appreciate what bone marking is articulating here. Right? What is sitting, what is articulating with these two? And I hope you're thinking to yourself, oh, those are the occipital condyles. The occipital condyles. So the occipital condyles are going to articulate here. Remember, the occipital condyles are on either side of the foramen magnum on the occipital bone. This would be a uniaxial joint, right? It's a pivot joint. The temporomandibular joint, as the name suggests, is between the temporal bone and the mandible. Between the temporal bone and the mandible. This is a really interesting joint. Incredibly important. This is basically your chewing, right? This is the joint that allows you to chew. This is a very complex joint in that this joint can move in 3 different movements. It's not freely able to move in all directions, right? But we can move in all sorts of directions. When you're chewing, you're not only moving up and down, but you're moving your lower jaw side to side, and then sort of almost an angular movement as well as you are chewing. And let's talk what's going on here. So in this temporomandibular joint, let me just point out a couple of the bone markings here. Number one, this is the opening in the temporal bone for the ear canal. This is the external auditory meatus in the temporal bone. It's not labeled here, but like I said, I'm going to try to point out as many of the bone markings as I can as we go through this. Also, we look up here at the top, this right here that I'm pointing to on the skull, this is the, what is this? Right here. Good. That's the mastoid process, right? The mastoid process of the temporal bone. As we're learning our muscles, remember the sternocleidomastoid muscle attaches here to the mastoid process. And what we see in the TMJ is that there's actually a big chunk of cartilage in here. So there's a disc in here. This is a piece of fibrocartilage, and basically the TMJ is 2 joints in one that allow this really complex set of movement. I'm not asking you to label all the other pieces here at all, but I just wanted you to see this really complex joint. Now this joint is, again, what allows us to eat. Our masseter muscle is helping to is allowed to move this joint. And people who have TMJ problems, right? Women have more TMJ problems than guys, and that can make eating very, very difficult. Shoulder joint, the glenohumeral joint. That's the name you're going to be using to describe this joint. The glenohumeral joint, let's take a look. It is the head of the humerus sitting into the glenoid cavity. The glenoid cavity, there is cartilage on both of those surfaces. Again, these are all synovial membranes that I'm describing today. So even if it doesn't show it, there's a synovial membrane around the joint with synovial fluid acting as a lubricant for the joint spaces. This is a ball and socket joint. In addition to what is shown here, there's also a labrum. Labrum is lip. It's a lip of fibrocartilage. And you may have heard of someone who has torn their labrum. Both of the ball and socket joints have a labrum. The glenoid labrum is basically a little extra piece of cartilage that goes around the glenoid cavity. And we'll see the same thing in the hip in the acetabulum. There are a number of ligaments here. The coracohumeral ligament, for example, and the glenohumeral ligament. The great news about ligaments, my friends, is that they name themselves. So the coracohumeral ligament must be a ligament that goes between the coracoid process of the scapula and the humerus, and the glenohumeral ligament is going to be between the glenoid cavity and the humerus. In addition to the ligamental structures that hold this critically important joint together, there's also a series of muscles known as the rotator cuff muscles. You're learning those in Lab 4. You know that these muscles are the supraspinatus, infraspinatus, the subscapularis, and the teres minor. These 4 muscles are helping to hold the tendons of these muscles are helping to hold the shoulder together as well. Let's just take a look at the posterior view of the shoulder of the glenohumeral joint. We can't even see the joint, can we? The muscles here, the rotator cuff muscles are covering it up. But just to point out, here is the spine of the scapula. This is palpable on your back. Here is the spine of the scapula. Above that, right, superior to the spine, is the supraspinatus muscle. Right? It tells us exactly where it is. Supraspinatus, superior above the spine. So the supraspinatus sits above the spine, and it sits in a space that you'll learn is called the supraspinous fossa. Below the rib is the infraspinatus muscle, sitting in a space called the infraspinous fossa. Okay. This is the 4th of the rotator cuff muscles, the teres minor. Notice it goes from the scapula over to the humerus. And on the anterior side, the muscle that's not shown here, the only anterior rotator cuff muscle, is sitting under the scapula, and it's the subscapularis. The subscapularis, and it's sitting in the region of the scapula called the subscapular fossa. So you'll definitely be learning all of those muscles and how they fit into the scapula. And no surprise, because of all these muscles and tendons and ligaments sitting around, there are some bursa. There's a subacromial bursa and a subscapular bursa. As their names suggest, subscapular under the scapula, subacromial under the acromion. One relatively common disorder of the shoulder is called adhesive capsulitis, or more commonly frozen shoulder. This is a condition that can just appear in middle age for a lot of people. There is an inflammation of the capsular structures around the joint, and it causes an adhesive type of event whereby the joint doesn't move very well. So this is somewhat painful, but more restrictive in movement than it is painful, and usually resolves within 18 months on its own. Surgery is sometimes warranted, but typically this is simply something that sort of repairs itself over time. Let's take a look at the elbow joint. This is actually a uniaxial hinge joint. That's not hard to imagine. It's actually 2 joints. It's really the humeral ulnar joint and also the humeral radial joint. It's really kind of 2 joints all blended into the elbow. So again, it's the humeral ulnar joint and the humeral radial joint both together in one single capsule. For the elbow, there are 2 important ligaments. One is the ulnar collateral ligament. This is the ligament that comes along the ulna and comes around to the humerus and supplies support on the medial side. On the lateral side, you have the radial collateral ligament. Guys, these are not hard to imagine, right? A ligament that goes from the radius to the humerus on the lateral side, right? On this case, it's the lateral side. There's also a ligament that wraps around. Think like an annual once a year, right? A calendar goes around once a year, and how the sun goes around the earth goes around the sun once a year. There's an annular ligament that goes around the head of the radius. So these are the 3 ligaments that you'll be introduced to in the lab related to the elbow. Taking a look Let's take a look first at the this bottom picture, and we can see here is the head of the radius. It's a perfect circle, and going around that head of the radius is the annular ligament. On the side is the ulnar collateral ligament. This is the ulna, and it's going to wrap around and go up to the humerus. On the other side, on the lateral side, we're going to see the radial collateral ligament. It's going to go from the radius to the humerus. Now, let's talk about a couple of the structures of the elbow. The tip of the elbow, the tip of your elbow is called the olecranon. So here is the tip of your elbow. Everybody just kind of bend your elbow, touch the tip of your elbow. The pointy projection is this region right here. This is the olecranon. The other side of this notch, you can think of the ulna as having this notch, and the other side of the notch is called the coronoid process. Coronoid. So we have the olecranon process and the coronoid process. Together, they make up this trochlear notch. This trochlear notch of the ulna. So the ulna already has this letter U cut into it, doesn't it? So it's very easy to recognize. The radius, which sits parallel to the ulna, is the only bone with that perfect circle. So if you were in a geometry class, you would measure the radius of that circle. Another bone marking here, this bump that I'm pointing to on the radius, this is the radial tuberosity. And you'll get to know well that this is the attachment point for the biceps brachii. As we take a look, here is the shoulder from a lateral, sort of a sagittal view from the side, okay? And we can see here is the brachialis muscle coming down, okay? There is a typo here, but the brachialis muscle coming down. The biceps brachii would also come down here. On the posterior side of this, we see that here's the triceps coming down. So the triceps comes down and actually attaches to the olecranon process. You can see some bursa in here, again, helping to protect the joint from the tendons and allowing things to sort of move, slide, and move easily. So those are the main structures to know for the elbow. Again, know that it's a hinge joint. Know that it's a uniaxial joint. Know that it's a diarthrosis, right? A freely moving joint. Recognize that it is the humerus coming in contact with both the ulna and the radius. And you're learning about the different ligaments. The three different ligaments are the ulnar collateral ligament, the radial collateral ligament, and the annular ligament. Again, you'll see these in lab as well. Moving on to the coxal joint, the hip joint. This is a multi-axial ball and socket joint. It is between the head of the femur and the acetabulum of the hip. There is a labrum, again, a fibrocartilage lip-like structure that goes all the way around the acetabulum, sort of gives it a little bit bigger space. And again, a person can tear that labrum. Keep in mind, it's cartilage, so it's not going to repair itself. A torn labrum is likely going to stay torn. They will sometimes go in and do a surgery to stitch together or smooth out the torn labrum, but it is not something that will simply grow back or repair itself. In the coxal joint, there are four important ligaments for you to know. There's the iliofemoral ligament. It's going to go from the ilium to the femur. The pubofemoral ligament from the pubis to the femur. And the ischiofemoral ligament from the ischium to the femur. In addition, there is a ligament that attaches to the head of the femur at a little spot called the fovea capitis. The hip is prone to osteoarthritis. It's weight bearing, and it is therefore more likely to have that cartilage wear down, the knee being the next most likely joint to have those arthritic changes. As we take a look here, again, here is the acetabulum. There's an extension of fibrocartilage around the outside edge of the acetabulum. That's that labrum. At the very top of the head of the femur, there's a little divot, a little hole called the fovea capitis. And from that fovea capitis, it's on your bone marking list, there is a ligament, it has no fancy name, just the ligament of the head of the femur, and it comes out and helps to hold the head of the femur into the acetabulum. Again, all of those ligaments are here helping to support the weight and the movement of this joint. And if you kind of just look, the iliofemoral, the pubofemoral joints or ligaments, they all make sense as to where they go, right from the femur to the pubis, to the ischium, or to the ilium region of the pelvic bone. As we take a look here zoomed in, let me just recall a couple of bone markings. Here we can see the greater trochanter, that is labeled. Here is the lesser trochanter, it is not labeled. Here is that obturator foramen once again. And here is the pubic symphysis, where the two pubis bones are coming together, connected by a chunk of cartilage. Here is the AIIS, the anterior inferior iliac spine. From a posterior view, here's a posterior view. Again, we see the pubic symphysis, and there is that lesser trochanter right here. It's not labeled, it's not maybe even obvious, but this is the ischium. And right here, the issue will be kind of a roughened area. This is going to be the ischiotuberosity. And the ischiotuberosity is the attachment for the hamstring muscles. Moving on to the knee joint. This is the largest joint in the body. And it is actually 3 articulations. It is where the patella comes in contact with the femur, and it's also where the tibia comes in contact with the femur, and the both on the medial and lateral sides. Okay. There are rounded knobs on the femur called the condyles, medial and lateral condyles. You'll see those. The patella is associated with the knee. It's really a separate joint, but it is associated with the knee. And there is a ligament, the patellar ligament, that comes just below the knee and helps to attach the patella in its place. You also have the quadriceps femoris muscle group, right? All 4 muscles come down to one tendon, and that tendon is going down across the knee joint, down to the tibial tuberosity. Inside the knee, there are 2 big chunks of fibrocartilage. They're called the meniscuses. They really are the menisci. There's the medial meniscus and the lateral meniscus. Recall from chemistry class, if you had chemistry, you know that when you're reading the volume of a liquid in a graduated cylinder, that you read from the bottom of the meniscus, that little happy face, that little smiling face. If you've had chemistry, that makes sense to you. If you haven't, it's okay. But a meniscus is sort of a crescent-shaped, smiley face sort of cartilage into which the femur sits. And if you take a look at your skeleton, and you take a look at the femur and how it sits down on the tibia, I'm always amazed at how in the world our entire body weight is maintained as our femur sits on the tibia. There are ligaments here that help support this, and we'll get to those in a second. But as you look down, this is a superior view looking down on the tibia, you see that these 2 menisci, right, the lateral meniscus and the medial meniscus, kind of get the sense, right, that those condyles of the knee sit very cozy into these shallow impressions of the menisci. And then there are ligaments internally. There's an ACL and a PCL. We've all heard of these. You can't turn on ESPN without hearing about somebody who has torn or damaged their ACL. So the ACL, we'll take a look at it here in a moment. This is a sagittal view. We're looking at it from the side, of course, but the ACL is this little ligament that is connecting the femur to the tibia, and it crosses in front of the posterior cruciate ligament. So anterior and posterior just tell us where they are. Cruciate means cross. They crisscross over each other, and they're ligaments that connect bone to bone. So the ACL and the PCL. The ACL is there to stop hyperextension. The ACL becomes tight when the knee is extended and thus resists hyperextension. If you know someone who's ever damaged their ACL, typically they have their leg extended and then there's some sort of injury. Something falls on top of their knee or on their thigh and overextends that knee joint and the ACL pops. PCL does the opposite. The PCL, the posterior cruciate ligament, is a stronger ligament, so it doesn't get damaged as much, and it stops the knee from hyperflexing. Okay? So the hyperflexion is the job of the PCL, and the ACL stops hyperextension at the knee. In addition to those ligaments right where the bones come together, there's also a tibial collateral ligament. This is also referred to as the medial collateral ligament. It's on the inside. And there's a fibular collateral ligament, also referred to as the lateral collateral ligament, because it's on the outside. And those ligaments go right where you expect them to, from the condyle of the femur down to the bone of its name. So the fibular collateral ligament and down to the fibula, and the tibial collateral ligament down to the tibia. Here we see the quadriceps femoris tendon coming across. The patella is embedded in that tendon. Again, the patella is a sesamoid bone, and it comes down. Below there, we now have the patellar ligament. Patella is connected to the tibia, and all of this tendon and ligamental structure comes down and attaches to the front of the tibia on a notch called the tibial tuberosity. So definitely watch the video on ACL, and you can see this little story here is about a tear in the ACL and what is necessary to repair it. I'm not going to quiz you directly on that, but I do want you to understand what the ACL does. It stops hyperextension of the knee, and you can see here also in another story that if the meniscus wears down and you start having bone on bone changes, right, that can be surgically repaired, or the entire knee can be replaced. Oftentimes in a really bad injury to the knee, not only will the ACL get torn, but the MCL will also get torn. So that is not uncommon. If someone's hit from behind hard, the ACL and the MCL oftentimes will tear simultaneously. If you know somebody who's had an ACL repair, this is a great video to watch. Lastly, we're down in the ankle and foot. The ankle joint is better known as the talocrural joint. Talocrural, why? It is the talus connecting up to the crural region of the leg. Remember, that's the front, the shin, if you will, of your lower leg. And this is really an articulation between the talus bone as well as the distal ends of the tibia and the fibula. Here there are a couple ligaments that are involved. Don't worry about these ligaments because we're not looking at more detail in the talocrural joint in lab, but just appreciate how complex this is. We're not naming any of these ligaments. But oh my goodness, when you look at the complexity of these ligaments, look at that. All those little ligaments that connect all those little tarsal bones together. Remember, this is weight bearing, folks, right? This is weight bearing. And these ligaments have a very, very important job of holding all of that together. Also, though, be amazed, think back to that radiograph I showed you of the developing foot. These ligaments are not formed early on, right? These bones do not articulate until later. And so these ligaments are something that are continuing to be developed in our childhood. Bone markings here to be mindful of, as this is the fibula coming down. Remember, the fibula is more lateral, so this would be the lateral malleolus. And then on the other side, we can't see it here, you would have the medial malleolus. So that brings us to the end of our little run through on the joints. Keep in mind what's important. Naming the bones that are involved in these joints, knowing the ligaments, the same ligaments you learn in lab are the same ligaments I want you to worry about here. And they're the ones that I pointed out here today. And if I didn't mention it, it's not important. And also know the movement that these joints allow your body to do. So that brings us to the end of the Blossom content for this discussion. Let me now just click on a few slides to supplement this. And these, again, are posted for you at the bottom right underneath this lecture. And I think these are just really cool slides to look at, and they give us some important information. It might be obvious to you, but the glenohumeral joint is the most mobile joint in your body, right? Your shoulder does amazing things. It's multi-axial. Then the next most mobile major joint is the coxal joint, right? It's also a multi-axial joint. These are both ball and socket joints. They have the most mobility. But with that greater mobility comes a price to pay. These multi-axial joints are also the least stable, right? And so these are the joints that people have the most problem with, right? People have hip issues, they have shoulder issues, overuse, injury, trauma, whatever. So there's an inverse relationship between mobility and stability. The elbow is kind of in the middle, right? It's a little bit less mobile. It's only a uniaxial joint, as would be the knee. And they are more stable. Your intervertebral discs, these are cartilaginous joints, right? Very little movement. So very little movement, but very stable. And your sutures, which are the most immovable of all of the joints, are the most stable. So it makes sense. But it's a nice visual to see this inverse relationship between mobility and stability. I mentioned when we were discussing the bones, I didn't have this slide for you at the time, that osteoporosis is actually a disease of the spongy bone. Take a look at these two micrographs. These are scanning electron micrographs of spongy bone. Now, I think this is a little bit misleading, so I want to point it out to you, but notice that this is a 20x versus a 30x magnification. So here we're not seeing things as enlarged, but here you can see the spaces and those trabecula, which are the spiny projections within the spongy bone. And over here, in a person with osteoporosis, you can appreciate how, quote, porous the bones are becoming. They have these little holes in them, and this is again a disease of spongy bone. There are a number of medications that are prescribed for individuals with osteoporosis. Fosamax, Actonel are a couple of these. There are newer ones as well. But all I want you to think about is that these medications work by interfering with osteoclast activity. Remember, osteoclasts are the cells that break down bone. So these medications slow down osteoclasts, which can slow down the progression of osteoporosis, and that's a good thing. But I want you to also think about something else. If osteoclast activity is interfered with, what else would go wrong in this individual if not closely watched? Remember, osteoclasts, they have a purpose. Their job is to chew away at the bone in order to release calcium into the bloodstream. And we didn't talk a lot about that the other day. But if a person is taking one of these drugs for osteoporosis, that means that their body is not going to have the calcium that it needs because the osteoclasts have been shut down. I didn't say this yesterday or the last time, but calcium is necessary for your bones to work properly, to build, and calcium is necessary for your nerves to work normally, and calcium is necessary for blood to clot normally. So a person who's on any sort of osteoporosis medication is also going to be on calcium supplements and watching their phosphorus levels as well. I mentioned arthritis as being a type of disease and inflammation of the joints, and I described you the idea that there's multiple different types of arthritis. Let's just take a look here at this x-ray. And what you see here, and I hope you agree that this is the knee, right? We're seeing the femur come down and sit on the tibia, and here's the fibula over here. What I want you to see though, if this was a nice healthy joint, this joint space would be smooth, and there would be, you would be able to see the dark color in between the bones. And notice right here, right, there's bone on bone changes. And so this would represent a breakdown of the cartilage and definitely bone on bone. So this could be a very painful condition for this individual. So this is an example of osteoarthritis. In the other two x-rays, these are examples of rheumatoid arthritis. And what you see in rheumatoid arthritis are very swollen joints with dislocations. Notice how awkward these joints are, right? So if you've ever seen, again, this is more in women, if you've ever seen an elderly woman with rheumatoid arthritis, her hand is deformed from these arthritic changes. So that is characteristic of rheumatoid arthritis. That is also shown here. Right, look at this. This joint, this pinky joint, is completely off its location. And so you can see just how dysfunctional her hands are and how painful this would be as well. As I mentioned earlier, it's in that one of those little breakout boxes in the Blossom textbook. But arthritis is not a single disease, is like which most people think about, or maybe a couple of diseases, but over 100 different diseases. It's second only to heart disease as a cause of work-related disability, and it affects the everyday activities of millions of Americans. It doesn't affect just elderly, but there are also forms of arthritis that can affect children. Again, there are more forms of arthritis diseases that strike women, but there are some examples that affect men and more. And I've already mentioned these, but here it is in text. Osteoarthritis, degeneration of the joint, breakdown of the cartilage, prevalent in everyone, more common in the elderly, but it can start younger in life, but it's that breakdown of the articulating cartilage. Rheumatoid arthritis, an autoimmune disease, more likely to affect women. Gout, metabolic imbalances, which typically leads to changes in the big toe. This can be changed by some medications. And then others that you have probably heard of, lupus, scleroderma, fibromyalgia, because they all can affect joints. They're types of arthritis. And just to give you a name, ankylosing spondylitis is a type of arthritis that affects just the spine. Again, there are dozens of these specific types of arthritic changes that affect just certain bones or regions of the body. Last thought, here we go. Remember, we've seen this slide before, and it's an example that I gave you back in chapter 3 on apoptosis. I showed you the human embryo from week 5, about the size of a quarter, up to week 10. During that 5 or 6 week span, the arm buds extend and the fingers are individually formed as apoptosis occurs, and the bones are now separated, if you will, and the skin paddle separates. So what can go wrong during this period of development, right? As the arm is extending and as the legs are extending, what can go wrong? Here are a couple examples of limb malformations. Let me just describe them to you. The words should make sense to you. One is polydactyly. This is where there are extra. Poly means many. Dactyl, you know from your vocab for exam 2, means digits or fingers or toes. So polydactyly is having extra fingers or toes. Here we go. Right? These two figures are showing you examples of extra fingers or toes. Man, if you have an extra finger, maybe you're a better pianist. I don't know. Ectrodactyly is a lack of digits. Look here in the bottom middle. This looks more like a claw hand. So this is a birth defect where clearly the limbs did not form properly and the person is missing digits or has dysfunctional digits. And then there are people who are born with syndactyly. Again, we know that sim and syn both mean together. So this is where a person is born with webbed fingers, and you can see here that digits 3 and 4 are webbed. And you should be thinking already, what didn't happen, right? Apoptosis did not properly occur between digits 3 and 4 during this 6 to 12 week period, or this 5 to 10 week period during human development. What else can go wrong? There is a term, amelia, which is just a generic term that refers to a loss of a limb. This could be from trauma or it could be from a birth defect. Focoamelia is a type of short flipper-like limb. We're seeing that here in this baby. This young baby has short flipper-like limbs, and this would be considered focoamelia. What causes this? Okay, it's pretty rare, but back in the late 1950s and in the early 1960s, there was a drug given to women to help them with their nausea. It was called thalidomide. Know that drug, thalidomide. And thalidomide, again, was given to women to cause nausea. Now tell me, or to curb nausea, not cause it, curb it. When are women typically nauseous? Now some women are nauseous through much of their pregnancy, but when does nausea usually kick in early pregnancy? Well, it's usually right about week 5 or 6, right? So nausea kicks in right about here, right? I'm going back to this apoptosis slide to remind you of what's happening during this weeks 5 and 6 period. This is when the limbs are developing and the hands are developing. It turns out, now this drug, I should say, had been tested on animals, and there were no negative effects seen on rats, mice, and rabbits. So they did all the testing, and there were no negative effects on other mammalian critters. But it was soon discovered, after years of figuring this out, that thalidomide is a teratogen. A teratogen is a chemical that causes a birth defect. And we now know that thalidomide blocked blood vessel growth during this critical period of time, right? Women are taking this drug between weeks 6 and 10, 6 and 12, right when the limbs are developing. And thalidomide blocked the blood vessel formation, and therefore the limbs were unable to form. In other words, thalidomide stopped angiogenesis, right? Angiogenesis, the formation of of blood vessels, angiogenesis. Now, thalidomide is still used in some limited capacity because it does block the formation of blood vessels. It is sometimes given in chemotherapy cocktails because a tumor, right? It's a group of cells. Remember back to our conversation about cancer. Cancer tumors need to have a supply of blood. They need to create angiogenic changes. They need to have more blood vessels to support those cells in the tumor. So one way of combating a cancer is to block angiogenesis or neovascularization, right, the formation of new blood vessels. And so thalidomide is sometimes included in chemotherapy cocktails to help block the formation of blood vessels, which helps to shut down the ability of tumors to grow. And then I'll finally leave this here. We'll typically talk about what happens with aging, and that is as we get older, osteopenia will occur. Osteopenia, simply penia is a root that means deficiency in. So our bones become thinner, they become weaker. Osteoporosis is a type of osteopenia. Osteoporosis is a type of osteopenia. And with osteopenia, again, bone density decreases, our bones become more likely to break. Now, this osteopenia is more likely to occur in the vertebra, jaw, and the epiphyses. Well, what does this mean? This means that as we get older, we are likely going to get a little bit shorter because if all 24 of our vertebrae get a little bit more brittle and get a little bit smaller, right, then we can expect to get shorter. If we start having bony changes in our jaw, our teeth will start getting loose, won't they? And so with age comes instability of our periodontal ligament and of our teeth. And the articulating surfaces on our bones deteriorate. This leads to more of those osteoarthritis changes. Again, our skeleton is not static. It is changing through the years. And so our skeleton is changing and our joints are changing throughout our lifetime. And calcium changes are occurring by age 35 for women and for men by around age 45. So by 35 and 45, probably everyone should be looking at some sort of calcium supplementation to make sure their body's getting enough calcium. So these slides again are posted at the bottom of the presentation, and this ends our conversation on joints.